So good evening, everybody. Happy June. Great to see you all. We're really excited to have. Oh, where is this one? Okay. People not hear me. I have a big voice.
No, I'm sorry.
Is this one? Testing. My quiet, sexy voice. So it's great to see everybody. Before we get started, a few announcements. We've said it before, but we're always willing to take any unused medications you have. HIV medications, of course, but they do take other medications as well. And this goes to a clinic in Tijuana that the docs at UCSD help run. How's this? Testing. It's working. Testing. It's practically in my mouth already. Not that kind of program. So, yeah, I just got back to San Diego. So
Don't be afraid to talk very close to it.
took certainly huge bags and boxes. Thank you, Don. For all this stuff, but they're very grateful to have it. So anytime, if you know anybody who says, "Oh, I need to throw out some meds," we're happy to take. So anything up to about 5 years old, it doesn't matter if they're expired. Those numbers are just suggestions. They said most things are good up to about 5 years. So that's then, as you know, this will be our last program for the summer. We always take our break in July and August because it's too darn hot. We can try to get away then. So we'll start back in September. We'll be excited to see you then. And coming up in a week and a half will be our third annual women's conference. She is Conference for Women Living with HIV. So we're really excited about that. That'll be here at Mizell on Saturday, June 13th. So feel free to come. You don't have to be a woman. Allies and friends and other people are welcome to come as well. We've got some great speakers and breakout sessions and stuff for all participants. So we're excited about that. And 7 days in June. So later this is 7 days in June, and that's a project started by Cleve Jones, who is the creator of the AIDS quilt back in the day. And this is 7 days in June is supposed to bring awareness to the healthcare cuts that have been going on ever since who came into office. So we are part of that, and our part for HARP is going to be doing a candlelight vigil in the Rick Hardy Wellness Park this Friday, June 5th, starting at 7:30 p.m. And it's going to be in the Wellness Park in the north end where Timothy's bench is. And we'll be honoring those who living with and who've lost HIV. So please come. I'm sure it's in your inboxes. Yeah, question.
I think it started at 5. No, at 7.
The candlelight vigil, there's several events going on. So,
Yeah.
but the candlelight vigil is at 7.
At the wellness park. I think I read that wrong.
Oh, yeah. Yeah, that.
There's several events. How do we find out where they are?
We've been putting them on the website. I know DAP is doing something earlier in the day.
If you remember the village, it's been posted.
Yeah, it's been in the village as well. And just a reminder, if you haven't joined the village, it's a great resources. We've got over 400 people now, which is amazing. Less than 6 months ago, building 100.
Yep.
Yeah, so it's just amazing how quickly it's growing. We're getting interest from all over.
Put this down a little bit because I don't know why
So
it was right, but just
post
as
as many things as we can on
in
there.
the middle of the frame.
Informed
Okay.
and things.
No problem.
Thanks to Jim for keeping our web
Absolutely.
for that. And so with that, without any further ado, we're delighted to have Dr. Amanda Rittenberg here. And take it away.
Thank you. Thank you. Is it okay if I sit, stand? Can everybody hear me?
There we go.
Yeah.
Okay. I'm usually pretty loud, just in general from speaking. So thank you all for having me so much tonight. It's a pleasure to be here, and I really appreciate Brett and everyone at Eisenhower for welcoming me here. And thank you for dinner as well. So my name is Amanda Rittenberg. I'm one of the family medicine physicians at Eisenhower Health. I do primary care 3 half days a week. I'm also core faculty for the family medicine residency. So basically we teach a lot of residents. We do inpatient medicine, outpatient medicine. And then I'm also board certified in obesity medicine, metabolic health, weight, It's kind of been my passion for forever. And I truly think, especially in this day and age, it's such a rapidly growing field. So I want to be able to answer any questions you may have about that. And hopefully one day, be able to, oh, no, you're fine.
Sorry.
No, you're good. Is that okay?
Yep.
Can everybody hear me?
Yes.
And one day, if you guys have any metabolic health needs, any weight needs, want to lose, get metabolically healthy, we're going to hopefully be able to see you at Eisenhower for that. So I do not have any relevant financial disclosures or commercial interests. I don't work with any companies. I always tell patients I wish that I did, because then, then I could hook you guys up with better medications and, I wouldn't be having to work so hard. No, I'm just kidding. But I'm also not an infectious disease doctor or an HIV specialist. I don't see a ton of patients with HIV, even though these medications, especially for obesity and metabolic health, a lot of them do not have any contraindications. Even more so, these are indications for these medications. And this is basically my metabolic health perspective. For today's agenda, we're going to just speak about HIV and metabolism, the fact that cardiovascular effects and weight gain can really cause issues on your heart, on your lungs, really all over your body. We're going to talk about my favorite topic, which is GLP-1 medications. I'm sure everybody has heard of, Ozempic or Mounjaro and all that. And then also just small lifestyle changes, because really it's not just the medications. It's not just getting your HIV under control. It's not just doing one thing. It's all a large, component. And we want to make sure we're really doing everything that we can, because you don't want to do one thing without doing everything else, right? And if at any point anyone has any questions, feel free to just stop me. Just raise your hand or, just yell. No problem. I won't be offended. So really the new reality of aging with HIV is that we do have a new population. This over 50% of patients in the US now living with HIV are now over the age of 50. And this is amazing because of all the medications, even just being here for a couple of minutes, many of you have shared your stories, and it's absolutely amazing. And these are all new advances in medicine. That being said, HIV does cause accelerated aging, meaning your biological cells do age around 10 to 15 years faster. Many also patients living with HIV do have multiple comorbidities. That means diabetes, high blood pressure, high cholesterol. What does that really mean? That means that we need to do something to make sure we're preventing what we can prevent, right? You never know what's going to happen, but we can check your bone mass. We can check your kidney function. We can also check your brain and metabolic health. And the other thing is cardiovascular disease. We can have tests. We have tests that, help us. The other thing is, we want to make sure we are also telling our friends about this, because there's a lot of preventive things that we can do. And that's really what I'm trying to focus on. I also have to say, here in Palm Springs, we're very fortunate that we have a wonderful community, because that's not something where really I wouldn't say this population here, this beautiful population in this room doesn't reflect the national population, just based on the support system. Having that support in your friends and your colleagues in the community is extremely important. And we're fortunate to have that here. So what does that mean? Why is HIV so important, and why is metabolic health important? Not only, is having HIV a risk factor for cardiovascular disease, but it really increases your risk of having a heart attack by 3 to 5 times. 50% of patients living with HIV do have cholesterol problems. We call that dyslipidemia. That means when you get your lipid panel, you see the little, I know now everyone has access to my chart, or you get your printed out labs and something's in red, whether that's, the fat content, whether that's your good cholesterol, that's your bad cholesterol. That's what dyslipidemia means. 25% of patients develop metabolic syndrome. We'll talk about that. Not every patient with weight problems or with metabolic health issues has metabolic syndrome. It's a specific criteria. There's also a 2 to 4 times higher risk of type 2 diabetes. Why does this happen? Because of chronic inflammation. There's a constant low-grade inflammation, which just damages the blood vessels, liver, and the metabolic pathways. Older antiretroviral therapies can also cause a lot of side effects, which we'll kind of talk about briefly. But I do have to say, especially with the newer agents, we're seeing a lot less of this. There's also the immune activation and accelerated agents. Like I said briefly, 10 to 15 years, you can almost say your cells are aging rapidly, just based on the chronic low level of inflammation. The other aspect is also the gut microbiome. So I like to tell patients we have bacteria everywhere. Our skin has bacteria, and really it's almost our second brain is our gut. And when I was actually studying for my obesity medicine boards, there was a certain level of 2 different bacteria, And if one is higher than the other, it actually increases your risk of having weight challenges. The other thing I want to just say is, number one, being undetectable is really the best thing that you can do for your metabolic health, because if at any point, even any side effect of the medication outweighs, having active and detectable HIV. So I really like this photo because it kind of just tells us a little bit that HIV affects all the components, right? It affects our mucosa, which is the gut right there, the liver, the lymph nodes, spleen, and also all our immune cells. Even when you're undetectable, there's just this constant low level of inflammation. And I always like to think like a slow leak in a pipe. It's not really a flood, but over the years, it can cause damage. And luckily, we have lots of things that we can do, and also preventative things that we can, kind of ensure. Meta-inflammation is what we call metabolic inflammation, and it's this chronic low-grade state that we talk about. It's just constantly the virus, its effect, the gut microbiome disruption, as well as other metabolic complications. Despite successful antiretroviral therapy, people living with HIV often experience this constant low level of activation, and we can call it inflammaging. Even though these aren't terms I use on a day-to-day basis, I feel like they're so negative, right? But we really want to focus on all the positive things that we can do. And I actually like this diagram, and it just kind of represents how much is really changing in the metabolic space. And these are discussions you should have with your doctor, because even in the short amount of time, I like the picture, but one thing is wrong. NAFLD, non-alcoholic fatty liver disease, does not exist anymore. It is now called metabolic associated steatohepatitis, meaning taking away that stigma of alcohol. We don't want that, right? Like, we shouldn't be ashamed of any of our medical history. That's not anything we need to, this is why we're here. And medications are changing so rapidly, and we have such incredible medications. I mean, Cabenuva, patients are coming in for injectable PrEP. It's really the future of many medications, and also in the metabolic space. So this is just another same basically presentation as the other slide, but antiretroviral therapy suppresses the virus, but the other thing it doesn't suppress is inflammation. And that's kind of the main thing. Oh no. I hope everyone is okay. The other thing is too, what we need to always think about is our fat tissue in itself. I think everyone thinks, oh, fat is so bad, like the fat on our body, but actually it's a very metabolically active tissue, right? As patients lose weight, our fat produces so many different types of hormones. It produces angiotensinogen, number one. That's a hormone that actually causes your blood pressure to go up. Hence why we use a lot of medications called like ACEs or ARBs, let's say losartan or Cozar, olmesartan, telmisartan, lisinopril. That is one of the medications that actually blocks that hormone, and that's where it's produced. The other thing is, patients always tell me, hey, it's so hard to lose weight and keep it off. Why is that? Because fat actually produces a certain hormone. It's called leptin, and that makes you less hungry. That hormone inhibits a hormone in your stomach that actually makes you more hungry. So they're like, man, I eat less, but I'm still, gaining weight. So it's just really important that not only we need fat, we need that, and we want all the endocrine functions of it, and really we want it to produce hormones, but not too much. Oh no. The slide was going to be white. I'm not sure why it's dark. But one associated thing is HIV lipodystrophy. Lipodystrophy, what that means is fat like in a wrong spot, right? So for example, you can have it in your belly, that we call lipohypertrophy. Hyper means too much. And I'll have that on the following slides, are the photos. The other thing is, lipoatrophy is when you lose fat, and patients who shouldn't be on weight loss medications have been taking this in, pop culture, and we call it Ozempic face. When everything is really sunken in, you can also see loss of fat in your temporal area over here. But really the cheeks being completely sunken in is that what we call Ozempic face. And that just means you lose fat in tissues that you really shouldn't. This is lipohypertrophy. So it's another thing that's very important because, sometimes patients come in and they just say, hey, my belly's just getting bigger regardless of what I'm doing. And you can also have a fat hump on the back of your neck, and that's also not completely normal. And we want to make sure that we can, do what we can. The other thing is, especially abdominal obesity, meaning more fat on your belly, is actually more dangerous to your organs than other places. And these are just some more photos of lipohypertrophy and atrophy. So metabolic syndrome, this word I've been using so many times. What is this? It's really 3 out of 5 traits. It's having abdominal obesity, meaning that around your waist, so above, so there's these little things that we call our hips. And at a certain top of your hip, right above that is where you want to measure your waist circumference. And if it's above 40 inches in males or over 35 inches in females, that's one trait right there. It doesn't matter about your weight because someone can actually weigh, BMI is a great screening tool. And screening tools are great for, the masses, but not for your person itself, right? And so that's really important. You can have your doctor measure that, or even, bring in a tape measure. I have one at my office. I do tend to do that, especially if I think a patient would benefit. The other thing is the serum triglycerides. That means the fat content in your blood above 150 milligrams per deciliter. And that's really important because that goes along with the dyslipidemia, the cholesterol abnormalities, right? And, that's really important. If it's above 1,000, you can actually have pancreatitis. So you do want to get ahead of these things. And even if you're being treated for this with something called like a fenofibrate, that kind of medication, that's still the criteria. The next criteria is a low HDL. HDL is that good cholesterol. It takes the cholesterol from our blood and brings it back to the liver and actually helps us downgrade the amount of the cholesterol that we have in our blood. So if yours is low, below 40, that's not good in a female, or below 50 in a male. That increases your risk of cardiovascular disease. The next criteria is the blood pressure, and that means above 130/85, or if you're being treated for high blood pressure, right? The next criteria is a fasting plasma glucose of over 100, or if you're being treated for diabetes. So basically, when you go get your labs with your doctor, you can say, hey, do I meet criteria for this? And it's really important because, this is actually a bigger risk factor for heart disease than diabetes in itself, than high blood pressure in itself. So it's actually funny because it's usually a test question that we have on our boards. The other thing is how to measure your waist circumference. I like this photo because you want to make sure you stand up straight, you exhale, and then you can wrap a tape measure just above your hips. The other criteria is that, based on race and ethnicity, it's, we try not to say that, but it is a higher risk of cardiac disease and metabolic health. So for example, if you're South Asian, Japanese, your abdominal circumference actually needs to be lower in order to be healthier. Because really the goal isn't, hey, I want to lose 10 pounds before I go on vacation. My goal for my patients is making sure they don't have a heart attack, or if they have had one, that we keep them living longer. Why does this matter now? Because of the heart disease. We want to make sure we can, do everything we can. And we're in 2026. We need to make sure we're getting ahead of these things. There's a heart attack risk of 1 to 2 times higher in an HIV positive patient compared to an HIV negative peer. Atherosclerosis, meaning that you have a blood vessel. The plaques in the blood vessel, that goes a lot quicker based on all the inflammation. The other thing is the fat content in LDL, which is the bad cholesterol, it is more elevated on older antiretroviral therapies. We don't see it as much, especially, with Truvada, Descovy. These are really new and great medications. Type 2 diabetes. It's not only about, hey, I'm diabetic, hey, I'm non-diabetic. It's about insulin resistant. Insulin in itself is a pro-inflammatory cytokine, meaning that it causes more inflammation and it causes more just disruption in the body. And patients, when they go down on their insulin, they say, hey man, I just feel better. I'm not as tired all the time. I'm not as puffy. And the main thing is that all these rates are rising. Fatty liver disease, which now we call metabolic associated steatohepatitis. It affects 30 to 50% of people living with HIV. And I have to say, probably around 30 to 50% of patients without HIV as well. A lot of our patients tend to have that. And a lot of these things can lead to cirrhosis. I've had young patients that end up in liver failure and they've never had a drink in their life, but their weight is really the issue. The main thing is screening for all these conditions needs to be a part of your routine HIV care. You don't want to wait for any symptoms. Standard calculators actually decrease your risk. So, your doctor comes in, they say, hey, it's nice to meet you. We're here for your annual checkup. I always like to pull up the calculator so patients see kind of where I'm getting my data. And we use something called your ASCVD risk. This is a calculator that's based on lots of studies that tell us your 10-year risk of having a major cardiac event, heart attack, stroke, something like that. And we never know, right? A heart attack, will it be a large heart attack or will it be a small heart attack? Will it be a big stroke or a little stroke? We don't know that. And one really great thing is a coronary calcium CT. So I know we were kind of talking about briefly what to do before, you see your cardiologist. A coronary CT is a great scan. Make sure, obviously it's indicated by your physician, but it gives us a picture of your heart. And what it does is if this is your heart, it shows us the blood vessels and if there's any calcification. So, I have patients who they always say, hey, my cholesterol is in the 300s and I really don't want to be on a medication for that. And I said, okay, then this is a great option for you. It gives me an objective number. If that score is high, I know you have some calcium deposits and you're at risk of not only having that heart attack, but one of those calcium deposits can just plop off and then that can lead to a heart attack or a stroke. So we don't want to do that. The main issue with the coronary calcium score, which is an awesome test, my mom had one probably 10 or 15 years ago, is that it's usually not covered by insurance. Unfortunately, we just don't have, coverage for that. So I always tell my patients, hey, it might be an out-of-pocket cost. For most of the patients that have ordered it, they have completed it. And I don't know, depending on what center you go to, what that looks like, but most patients have completed that. The most important thing is really just checking your cholesterol. And you can check a screen prior to starting antiretroviral therapy at 1 to 3 months, and then routine, which is every 5 years. What to do about it? Statins. My best friend, he's also a primary care physician, and he loves statins. And he told me to tell my patients, well, if you knew you had leaking pipes in your house, would you wait until they burst? No, you wouldn't, right? You'd want to prevent that. So that's kind of what statins do. You have the coronary calcium deposits and they can, they actually stabilize them, not only from dropping your cholesterol, but whatever is there, they prevent it from kind of popping off. If you've ever had a heart attack or stroke, you're going to be on one of these medications for the rest of your life. Rosuvastatin and pravastatin are the preferred medications, and they have less interactions. These medications are metabolized by the liver, which most of the HIV medications are as well. So when you start getting in those sticky situations with multiple medications, you want to make sure one is not causing the other level to go up. And I actually have a list of these, we call them the CYP enzymes, inhibitors in my office. So it's, but your doctor will go through this and it shouldn't be an issue for them. There was actually a trial back in the day, I believe this was around 10 years ago, it's called the Reprieve trial, that showed that pitvastatin reduced the cardiovascular events by 35% in patients with low to intermediate risk, meaning 4.5 to 5% of this cardiovascular risk.
That study was done at Eisenhower.
Really?
Yeah,
Oh.
Dr. Stapleton, Dr.
Amazing. So, and we prescribe these medications. It's incredible. And where do you want your bad cholesterol to be? LDL is the bad cholesterol. Really, you want that number to be below 100. If you've ever had a heart attack, if you've ever had a stroke, you want that to be below 70. There are new guidelines that came out actually like 2 months ago, and they actually want that to be below 55, which is very hard. Another aspect I just want to say is there's only so much you can do to get ahead of your genetics. For example, I'm pretty healthy. I work out, I try one at least twice a week. My LDL, which is the bad cholesterol, is probably 120. And there's just nothing I can do about it. So that's just your genetics. That's the one thing you can't, lift more weights or exercise more. The other topic is aspirin, right? Back in the day, I think Bayer sponsored, some ads saying everyone should be on a baby aspirin. That's not true. Not everyone should be on a baby aspirin. It should only be used if you've ever had a heart attack or stroke, or your doctor tells you, hey, you should be on an aspirin. I have patients who come in and they're like, hey, I've been on this for 50 years because my doctor told me that I should be on one, just a baby aspirin a day. You really shouldn't unless you have an indication, because it can also increase your risk of having bleeding, and we don't want that. Where do you want your blood pressure to be? Below 130 over 80 is, ideal. This is another spot where family medicine kind of gets into it with internal medicine, because we use different guidelines. I think in our population, I'm not as aggressive with blood pressure because you can also be dizzy if your blood pressure is too low. So we kind of want it to be in a good medium. So really below 130 over 80 is good. Type 2 diabetes is also a side effect, and it's actually a disease of carbohydrate metabolism that can be due to antiretroviral therapy or in obesity itself. It's a disease that's characterized by a high blood glucose. Basically, you eat something, regardless of what it is. We're all enjoying our sandwiches, our cookies, and then what happens is you have your pancreas, and that releases insulin. That's a complete natural response. You want to do that. But if you have more tissue and more body mass, your pancreas can't, it has these little beta cells on there. And I just like to imagine them like, you know, like little ants building up, building up, building up. And at a certain point, if there's so much tissue, these cells just give out. And that's what type 2 diabetes is. Type 1 diabetes is an autoimmune response. And so these patients do require insulin. I'm not going to get into that just because that's, you know, diagnosed usually at a much younger age. And that's the pathophysiology, meaning how it is usually just completely different. Symptoms, what you guys should look out for. High blood sugar can lead you to pee more often. You can feel thirsty all the time. Wake up at night to urinate, and not because of the prostate, right? So there's kind of that, we need to make that distinction. The other thing is blurry vision, rapid weight loss. If you lose, I don't know, 30 pounds in 2 weeks, that's always a problem. When your blood sugar is too high, what happens is your kidneys, they don't hold all the sugar. So you end up peeing a lot of it out. And that can also lead to like urinary tract infections. If all of a sudden you're like, hey, I'm getting these recurrent happening like once a week, a UTI that kind of hurts to pee, it's just not feeling all right, you know, you need to get checked out. The other thing is, you know, constantly feeling thirsty, especially if you're drinking something that's sugary, right? That can even increase your blood sugar. How to diagnose type 2 diabetes. So this is actually quite interesting. In patients living with HIV, your A1C level is actually lower than a non-HIV positive patient. In the normal population without HIV, it is an A1C of 6.5 or above. Anything in a patient that is HIV positive, it's above 5.8. And that's due to certain things. And that's actually not only in HIV positive patients. If at any point, you know, you have anemia, that can actually falsely lower your A1C. So if you're constantly degrading your blood cells, regardless from any other cause, sometimes a heart valve can do it or even a genetic syndrome, that threshold to diagnose diabetes will actually be lower. And I hope this changes to 5.8 just based on the population. And, you know, we're missing a lot of patients that could benefit from medications to really get them feeling better. So really, when do you want to screen? You can screen at 1 to 3 months into your antiretroviral therapy, and then every year after that. If your A1C is below the 5.8, you can do lifestyle, and metformin is a great medication. It's an older medication. The main risk factor is in your kidneys. You need to, you know, keep an eye on that. And where do you want your A1C to be? That's a discussion with your doctor, but really you should be below 7. I think everyone in this room should be below 7 because, I mean, y'all look very young, you know, healthy. That's what we want, right? The thing is you also don't want to be too aggressive with medications because one, low blood sugar can kill you. High blood sugar takes probably around 10 to 15 years to cause its damage, right? And diabetes causes damage in, you know, in the eyes and the kidneys and the joints, you know, in the blood vessels. So patients can lose limbs. But in this day and age, it's very rare to see this since patients do a lot better. So like we kind of talked about briefly, you do want higher A1C targets. Some experts recommend, you know, an A1C of 7 to 8 rather than below 7, especially if you're older. Is metformin the first line? It is historically. I do think this is changing. And metformin is now being used more for prediabetes. But it can reduce your cardiovascular risk, which is great. That being said, if your kidneys aren't exactly where they need to be, then you can kind of, you know, have some side effects, which we don't like. The other thing is it can actually cause a lot of diarrhea. Patients don't like that. So I always recommend taking the longer acting form and taking it at nighttime to hopefully help. I really like it for my patients who are on a GLP-1 weight loss medication, such as Wegovy or Zepbound, and they say, man, I'm really constipated. And I said, I have just the thing. Well, then we'll balance you out. The other medicine I really like is an SGLT2 inhibitor, Jardiance. I'm sure everyone's seen the commercial. I think they're dancing. Is that? Yeah, that one. So, yeah. So Jardiance actually causes a decreased risk of cardiovascular, sudden cardiac death and all that, especially in patients who have prior cardiac disease. It's also part of our goal-directed medical therapy for heart failure, which is, you know, a big scary word, but now, I mean, I have 95-year-old patients with heart failure who have had heart failure for the last probably 30 years. We have certain guidelines that we can use, and Jardiance is a big one, and that's empagliflozin and dapagliflozin. Yeah, what it does is it pulls the sugar into your urine. And what I like to think of is sugar is just like salt. the more sugar you have in your urine, it's pulling all that fluid in and you're peeing it all out. So unless you're taking like Lasix, so that's also a medicine that makes you pee, and it lasts for 6 hours. That's why it's called Lasix, you know, the six. It actually, yeah. Mhm.
I had all in TBS and went to go. And I was taking a weekly dose of Trulicity.
Okay.
And given all my other issues, she recommended that I change it to Manjaro because she said the Manjaro was better or easier on my heart. So are the different?
Yeah. So Trulicity is an older GLP-1 medication. Off the top of my head, you know, I don't use it as frequently just because, so GLP-1 medications, you have a whole spectrum. Trulicity, I believe, so it is it's once a week, right?
Right.
So it's just like Ozempic or Mounjaro, which are all indicated for diabetes. So everyone who's out there on Ozempic, they're not on Ozempic. It's only FDA approved for diabetes. The other issue with Trulicity is, number one, we don't have the studies to back it up. But I still wouldn't recommend Mounjaro personally. I would rather do the Ozempic.
Well, my
Yeah.
practitioner,
To Ozempic?
no, I'm on Manjaro.
Oh, well, so here's the thing. We just don't have the trials to back it up with Mounjaro. We do think it has cardiac benefits, but Ozempic is the one that has these cardiac risk reduction trials behind it. And there was all these trials, they're called the SELECT trials. And I mean, they are sponsored by Novo Nordisk. So you have to take every trial with a grain of salt, right? And that trial did show a 20% reduction in cardiovascular disease on Ozempic. I do think, like, I love Mounjaro. I think for my diabetic patients, it's like my go-to. I had a patient in clinic with an A1C of 15. And 5 years ago, even 2 years ago, he would have been on insulin, poking himself 10 times a day, you know, injecting himself. And just on Mounjaro, he's down to 5.2. So, and he's lost 70 pounds. So, yeah. Bone health is something we kind of forget to think about. I mean, I know especially, in my clinic, I don't usually ask my male patients about their bone health, which I mean, we should be asking them. Because in females, you screen for osteoporosis above the age of 65. You always get this DEXA scan, which is a bone density scan. But in any man really above the age of 50 or with a risk, we should be using a FRAX calculator, which is this online calculator. It gives us a risk assessment, right? We don't want to wait until you have a fracture. Hip fractures are terrible. We don't want anyone to get that. The other thing is any other fracture, you need to tell your doctor because we can screen for it. Another thing to consider is vitamin D deficiency. That's very common, even though we live in such a sunny area. It is really important, you know, to make sure your vitamin D is above 30 at least. So that's, you know, I always tell patients I'm probably the most vitamin D deficient person out there. What can you do? You can do vitamin D and calcium supplementation, and then I will get into the dosage at the end. And the other thing is weight-bearing exercise. So go to the gym and lift some weights. You want to put a little bit of stress on your bones. Speaking about medications for osteoporosis, they're effective when your score is below 2.5 or your doctor says, hey, you know, I think you might be at risk of having a fracture. Kidney health is something we kind of look over because it's screened for so routinely. Anytime you go in, you get your CMP, right? Or even something called a BMP, comprehensive metabolic panel or basic metabolic panel. That always has the little number at the bottom. It's usually at the bottom. It's called GFR or eGFR, creatinine. Those are all things that we screen for. And as you get older, your kidney health is going to go down. That's just completely normal. You're putting miles on a car, right? You know, if you have a 100-year-old patient, their kidney function is not going to be the same as someone who's 20 years old. That's completely normal. But the chronic inflammation can really add to that. And so we just want to be, you know, proactive and keep an eye on that. And some medications might need to be adjusted, but that's usually when your GFR gets very, very low. I always tell my residents, hey, just, you know, we have these apps and we just need to make sure everything is dosed for the kidneys. What can you do is avoid taking Advil or, you know, naproxen, all these medications, especially for long durations at a time. You want to talk to your doctor and say, hey, you know, I'm having this pain. Really get to the bottom of why you're having, like, let's say, you know, your knee hurts, right? We should be able to tell you, hey, it's not XYZ, it might be this, and really go through what is kind of happening. And also the GLP-1s, so like Mounjaro and Ozempic, are actually protecting the kidneys too. So there are so many things that are happening with these medicines that we're shocked by the side effects, quote unquote side effects, but really the metabolic benefits. So sleep disorders, very common, especially, in the male population. Sleep disturbances affect around 50 to 70% of patients, and especially more if you do have HIV. Some medications can cause vivid dreams, but also, having weight issues can increase your risk of sleep apnea. If you're feeling tired every single day, you need to talk to your doctor. You should not be feeling exhausted and waking up 10 times a night if it's from going to the bathroom or just feeling very, very sleepy. I always tell patients, hey, if you think you have sleep apnea, we need to do a sleep study. Make sure. I've had patients who wake up 60 times in 1 hour. It's like mini wake up like sessions that happen. And then they have low blood oxygen levels, so it can cause increased blood pressure and also increased cortisol. Why does this really matter for your metabolism? Because constantly being sleep deprived puts your body in a very stressful state. For example, when I was in training, I would work night shifts for 2 weeks. For the first week, my body, I just felt like I was, almost like in a dream. When you go home after working 12 hours or not sleeping right, you don't want to go home and eat a piece of lettuce. You want to go home and eat something yummy. You want to eat that burger. And that's all these hormones actually acting on your brain. So it's really important. If you have sleep apnea, please use your CPAP. It's really, really important. The other thing is now we have the first FDA-approved medication for the treatment of moderate to severe sleep apnea, and that's Zepbound, which is a once-a-week injectable. It's for patients who have a certain number of these awakenings and obesity, meaning a BMI of above 27 or above 30. And so it's really important. And the CPAP, please use your CPAP.
You said that men suffer more from wakefulness or not sleeping well. Are there certain physiological or what are the impacts?
Yeah, so also men have a little more like their necks are wider, which can contribute to sleep apnea. Also, having testosterone deficiency can lead to that, and perhaps stress. Yeah.
The stress.
Yeah, the stress. And also females, for some reason, it seems like their neck muscles are a little bit stronger because sleep apnea, especially you have central or, normal obstructive sleep apnea when your muscles kind of like give out almost in your neck. And that can lead to collapse of the airways. And that's why you're waking up so much. And we just see that more common in men, especially men who are overweight or obese. Yeah.
Do you eventually work on weighing yourself up from the mask? Or is it?
So usually it's permanent, especially if there's no cause. Like, for example, if you have obesity, you can usually treat the underlying disorder and then patients do better. But there are different types of masks, but usually once you've had it, if there's a cause for your sleep apnea, sometimes there are centers in our brain, we call that central, that actually just are not triggered as much, and that can lead to that. Or peripheral, and usually that, based on the mask, yeah, you have to stay on it. There is a new device out there I've heard called the Inspire, which is, yeah. So that's the other treatment, but I'm not a sleep specialist, I don't know. I haven't had any patients. They like their CPAP machines, to be honest. They have really good new ones and they have smaller masks. It's an implantable,
Almost like
yeah. And it stimulates, I believe, the hypoglossal nerve, if I'm not mistaken.
wires that go up.
So they give like a nerve stimulation to basically treat the sleep apnea. Yeah, I've had 1 or 2 patients that get the device. They seem to do well. I mean, but with all the advancement of this CPAP machines too, patients tend to do really well. And there's different things. So talk to your provider, because I've had patients who come in and they say, hey, I'm just not going to wear that big mask. And I said, okay, well, there's the nose piece. There's a lot of different options, and we're moving in that direction, especially, with the prevalence of obesity in America, that there are lots of different things that are coming out. So my favorite topic, GLP-1 medications. So, everyone's like, oh yeah, these are new medications. They're not new. They've been around for around 20 years. There's Trulicity, Saxenda, which was a daily injectable, duraglutide, all the tides. These medications act on receptors that basically cause you to be a little bit less hungry. They actually also work in the brain. So they cross the blood-brain barrier, because all of our pleasure sensations and all of our pleasure centers are actually in our brain. And that's why they're so effective, because they decrease the amount of food you want to eat, but they also increase your insulin sensitivity, and they're wonderful. Who are they for? They're for patients with a BMI above 30 without any condition. So someone's 20 years old, they're on the street, they're overweight with a BMI of over 30, or a BMI of over 27 with any comorbidity, meaning they have high blood pressure, high cholesterol, all that. How do they work? They reduce our appetite and food cravings via the hypothalamus. That's our like pleasure sensation center. And really what I like to say is these medications act as, after you've eaten your sandwich, you're feeling really full and really good, right? How long does that last? Until you're like, maybe I'll take another bite. Like 90 seconds? Maybe? Yeah. So our natural body GLP-1, which is released when you eat from little cells in our gut, actually lasts around 90 seconds. So these medications act on those receptors to give us that sensation of feeling full. And that's really their best effect. They also increase our natural insulin secretion, decrease our glucagon, which just improves how well you're secreting the insulin. They also, they're working on the heart. And one thing we are seeing is like Ozempic for the heart or Wegovy, it actually decreases the glucose uptake of those cells, meaning, the heart blood vessels, when you take in glucose, they get thicker. So here, actually, this really helps. And this stabilizes the membranes. And I mean, it's incredible. So they're protecting the heart, they protect the kidneys. And honestly, they reduce the post-meal blood sugar spikes too. So patients who have terrible diabetes, all of a sudden, we're under control. Semaglutide, which is Ozempic or Wegovy, is a once-a-week injection at 0.25 milligrams up to 2.4. And actually, since I believe 2 weeks ago, they've come out with a new high dose Wegovy at 7.8, which I have not prescribed to anyone just because it's so new, just got FDA approved. And it's an amazing medication in the fact that it's approved for type 2 diabetes and it should only be Ozempic. If you're going for weight loss, you should be on Wegovy. And also it's improved, FDA approved for type 3 fibrosis and metabolic associated steatohepatitis, protects the kidneys, and also for cardiac outcomes in patients who have a history of any cardiac disease. One also thing I do want to say about these medications is please, please, please see your provider for them, right? Compounding as of May last year is not legal. So unless your medication is coming with one of these brand names on it, it's not the real thing. I like to think of compounding as a knockoff. You never know what you're getting, right? So a lot of these things, these peptides that patients, people are getting from, the gym or, they're even these billboards driving down the 10, you see, those are not these medications. And you never know what you're getting. And at a certain point, you have to be careful, right? Because they can have side effects. So it's kind of the other thing. Tirzepatide, which is Mounjaro or Zepbound. It's a dual agonist, meaning it acts on GLP-1 and GIP. GIP is another hormone. This whole class is called incretins. They're all these hormones that make us hungry or, make you want to eat. The GIP component is gastric inhibitory peptide. That's the big name. And adding that to the dual, like the GLP-1 component, decreases nausea. It also increases the weight loss. That's why semaglutide was like, we need to come up with a higher dose in order to compete with Mounjaro or Zepbound. A little caveat though is patients who are diabetic, they tend to lose a lot less weight on these medications. Their blood sugars are great, but they're just not losing as much weight. And then there's Foundayo, which is the newest and latest and greatest medication that Eli Lilly just came out with. It's orforglipron. It is a receptor agonist, but it's not like a GLP-1 in itself. It's a small molecule. So the issue with like semaglutide and tirzepatide is if you were to take the injection and let's say put it in your mouth, please don't. It gets degraded by your stomach enzymes and also the acid, right? So Eli Lilly came out with something called the small molecule, which doesn't get digested. And that's the beauty of Foundayo. That being said, though, it does have many medication interactions because it does get degraded by those liver enzymes I was talking about. So please, please speak to your doctor prior to Foundayo. It is going to be, I think it's a lot cheaper than the other medications currently out there. And most of these, so there are two big brands out there, in the metabolic space, and that's Eli Lilly and then Novo Nordisk. And both of those do have cash pay options. So when those medications used to be $2,000 a month, they're now starting, depending on which medication, from $149 anywhere to $300. And that's going to change July 1st because Medicare Part D is going to start covering these medications for a $50 a month copay, hopefully, as part of the Bridge program. So there's some other oral weight loss medications. There's the Wegovy pill. Is there a question? Oh, no? Okay. So there's the Wegovy pill. And that one, is it's good. I don't like it as much just because of the nausea. Patients tend to do better on the injectable once a week. You know, you just set a reminder on your phone, hey, every Monday is injection day or every Sunday is injection day. Contrave is a longer acting, you know, it's an older medication. Now it's naltrexone, bupropion, we were talking about that. Naltrexone's a medication used for cravings. So if you have any history of drinking, that might be a great option. And you want to cut back on the alcohol. Qsymia is an older medication. It's with topiramax in it. It's an old anti-seizure medication. It causes a lot of weight loss. But all of these do not compete with the new medications, especially Zepbound and tirzepatide. Phentermine used to be the good old fen-phen. I'm sure that was a thing. So there, we still have phentermine. We just don't have the other component of it. The other component was the fluvenamine component, and that caused heart problems and all that. So they took that away. And you can use phentermine for a little bit more weight loss for around 3 months. That's what it's FDA approved for. Why are these beneficial? Because really total body weight loss on these medications is around 15 to 22% with semaglutide. On tirzepatide, it's even up to, 25%. And I have to say, back in the day, 5 years ago, we had nothing that rivaled these numbers. If you were losing 20% of your body weight, you were getting bariatric surgery. And now we still have those options, but we also have these medications. And these medicines really do help with antiretroviral related weight gain. And they do counteract the weight gain, especially from certain medications. They improve the lipodystrophy symptoms. And we don't know of any interactions so far. There isn't that much data, but the most important thing is that we know that especially they don't work on the liver, they don't get degraded by the liver. So that's why it's a great option. And they do protect your liver. Lots of anti-inflammatory effects too. We're seeing that patients are having less joint pain, less hip pain, less knee pain. So it does appear that there's a large amount of inflammation that does go down. What do you have to think about, right? Drug interactions. It's always the most important thing is just to talk to your doctor because, I've seen patients a couple times and they don't even tell me that they're on a medication, that they're getting from their, hairstylist or, from their gym buddy or they're on retatrutide, which is not FDA approved. That's the new medication that's currently in phase 3 trials. And they, so they don't, you guys just share this with your doctor. If any physician is not saying, hey, I'd like to help you with your weight if you need it, then that's not the standard of care. We want to make sure, we're providing the standard of care. The other thing is you want to talk to them. Hey, is metformin an option? Sometimes, to just improve that A1C a little bit, you can do that. There isn't any specific routine monitoring for patients living with HIV with the viral load and CD4 count, but we don't have the evidence to back it up. So if you are going to start one of these medications, talk to your doctor, and perhaps for the first 3 months, your labs can be drawn a little bit more frequently. I always tell patients, hey, I'd rather be more safe. And sometimes I do things just to make myself feel better. I'm like, okay, let's just get this lab just to make sure, right? And this is a whole space we're entering that there isn't a ton of data and documentation. So if there's something that we can do to make you feel better, make us all, feel like we're doing the right thing, we definitely want to do that. We also want to check your kidney function, your liver function, whenever you're starting any new medication, and then at 3 to 6 months. We also have been seeing significant improvements in cholesterol. I've had to take patients off their cholesterol medication because it's just too low once they've lost 70 or 80 pounds, right? So you definitely need to adjust medications as needed. The other thing is, as you lose weight, your blood pressure is going to go down. So please see your doctor frequently, to make sure, hey, am I on the right amount of these medications? With every medication that you're on, the drug interactions go up significantly. For example, if you're on 4 medications, it's not 16 interactions, it's 256 interactions because it's 4 to the power of 4, right? And I had to Google that math. So really the common side effects of these medications are nausea, vomiting, constipation, or diarrhea. And the main key thing is start low and go slow. I had a colleague who recently told me that he saw some online physician who started him on 7.5 milligrams of a medication for weight loss. And I said, yeah, that doesn't sound about right. You should be in at least your 3rd month of treatment at that point. He's like, no, they said it was fine. And I'm like, no, because there really are side effects. You can get pancreatitis. You can have gallbladder issues. And the main contraindication is a personal or family history of medullary endocrine neoplasia type 2 or thyroid cancer, but only the medullary type. That's very important. Other thyroid cancers are not a complete contraindication. You may be a good candidate for GLP-1 therapy if your BMI is over 30 or over 27 with any weight-related conditions such as diabetes, high blood pressure, sleep apnea, or heart disease. If you've had a ton of weight gain after starting your retroviral therapy, talk to your doctor. Sometimes, as physicians also, we do things off-label. I think weight is one of those things that's really related to your mental health as well. And a lot of patients just don't feel good at like gaining 20 pounds, right? You don't necessarily want to say, hey, I think I meet criteria, but sometimes I'll say, let's do a short course or, not that necessarily it meets indications, right? If someone is going to feel significantly better, their cholesterol is going to go down, their blood pressure is going to go down, that is worth sometimes having the discussion with your patients. The other thing is trying lifestyle changes with only limited success. Saying, hey, I'm going to the gym 6 days a week, every week, I'm doing all the things, it's just not working. Have that discussion with your doctor because we have the tools in the toolbox to help you. Like I said, if you have medullary thyroid cancer or a history of multiple endocrine neoplasia, these are not for you, unfortunately. It's very rare. I have never seen it, knock on wood. If you have any severe motility disorders in your belly, meaning you've had diabetes for X amount of years and, you eat and then you feel like throwing up, talk to your doctor because these medicines do slow down your digestion. So your food sits in your tummy longer. And obviously if you've ever had an allergy to the medications. Nutrition. The most important thing for nutrition is really protein. Why do we want to eat more protein? Because that helps us with our muscle loss. We don't want to lose muscle. Anytime you lose any weight, you're going to lose some muscle, but we want to prevent that. For example, you really should be eating 1.4 to 1.6 grams per kilogram of your body weight. So if you weigh 200 pounds, you should be eating 125 to 145 grams of protein a day. That's a lot. That's a really, really big amount. And really, you should be having 25 to 30 grams in each meal maximum, because if it's too much, you can't absorb it all. Why does this matter? Well, because we don't want you losing as much muscle. So if you can increase your protein intake, and making those changes is really important. And, it's not just, hey, take this medication, you're going to do great, you're going to lose weight, good luck. No, your physician and your nutritionist should all be counseling you on these changes. The other thing is patients come into me and they say, hey, what diet do you recommend? And I said, well, ideally I always say, hey, Mediterranean diet. Well, what does that mean? That means that you're eating lots of beans, lots of healthy fats. We want you doing olive oil, all these things. But really a diet that you're going to stick to is the best diet. And if that's taking out one little thing every week, or making that one change, that's what we want. At the end of the day, we're all people. We have one life. And I think food is very important. It's a culture, you come home, you've had a bad day, you want to eat something good. You've had a great day, you want to have something good. So everything in moderation. The other thing is fiber. We want to eat at least 30 to 35 grams per day, which actually supports our gut health. And that actually lowers our cholesterol as well. Most people are actually vitamin D deficient, even in the desert. As you age, your skin does not absorb the vitamin D like it used to. It's just one of those things. And really, we should be taking 2,000 to 4,000 units a day. And that supports our bone health, our immune health, as well as metabolic functions. The most important thing I think I can say is also to decrease the amount of ultra-processed foods. If something looks like it's made in, it's not natural, it's probably not great for you. I like those cookies when you go to the store, the pink ones with the little frosting, like the really soft white ones. I don't think those are like, super healthy, right? But it's definitely something that, you can have once in a while as long as it's not every day.
Your slide says that's for men. What are the recommendations? Any different for women?
A little bit lower, yeah. 1.2 to 1.5 grams. But it's really not possible to eat that much protein. I've tried, but I'm eating like every hour, I don't know how many eggs a day, and it's tough. The other thing is too, I always tell patients to take it with a grain of salt, because I don't want you going home and drinking a protein shake. That's, again, going down that ultra processed route, right? So, as much as you can possibly, and protein can also cause you to be constipated. So drink lots of water, at least, should probably be drinking 6 of these a day, at least, unless you have heart failure, then 6 of these bottles of water a day. Yeah. Unless there's so 2 to 3, depending on, and for example, not for everybody, right? So if you have heart problems, then you definitely need to not drink 2 to 3 liters a day. So then we usually limit it to like 1,500 milliliters, which is 1.5 liters. So again, the most important thing is, before actually coming out to the desert and starting my training, I didn't know that you could drink too much water. but we have patients who come into the hospital because they stop their water medicines that help them, urinate their water out, and then they come in, with too much fluid. So there is such a thing as drinking too much water. Salt, yes. So really we should be intaking less than 2 grams of salt a day. Unless you have another condition, such as heart disease, like heart failure, it's less than 1,200 milligrams, which is really tough. Like even look at a box of, so 2 grams is usually the standard, yeah.
Is that like a teaspoon?
I don't know how much that is exactly, but usually, yeah, around there, teaspoon. But please just look at what you're eating because everything has salt in it. Even like, I remember the other day I was eating some Lucky Charms, the once a week rule. I really like them. The once a week, man. I gotta have my Lucky Charms. And I'm like, how much sodium is in this? It's insane, so everything has sodium in it. Yeah. It's really the combination. Yeah, I like the little, the pink ones. Once in a while it's all about balance, right? That's also the day I go to the gym. So, we balance it out. So yeah, there's quite a lot of salt in everything. Even, your beverages, Diet Coke, for example, has sodium in it. So it's everywhere and we don't even see it. Resistance training is huge. And it's really important to prevent any type of muscle loss, not only in patients on GLP-1s, but lifting weights, right? I know, you go to the gym and you do some cardio. So cardio is great. We want you hitting 150 minutes of moderate intensity exercise a week. I tell my patients that and they look at me funny, like, what are you talking about moderate intensity? So whatever your age is, minus 220, and I'm sure I won't be able to do that math in my head, so I always write it down. 60 to 70% of that is your moderate intensity heart rate. And we want you to do that for around 150 minutes a week, whether that's 5 days a week at 30 minutes or, 3 times a week at 50 minutes each day. You should be doing that. Even walking 30 minutes a day significantly improves your metabolic health. Group fitness is great. It kind of improves adherence. You want to get some buddies and go and do as much walking as you can. Obviously, it's very hot here. So if you want to go to the gym, you can do an incline. And then really, this helps with a lot of things. Exercise releases endorphins. Endorphins, help also make you happy. So this can help some depression and anxiety, especially these having support groups and, body neutrality. Patients come in and they tell me, hey, I want to lose weight and their BMI is 20. And I look at them and I say, no, I won't put you on this medication, unfortunately. We have patients that come in like that, and then it's doing a patient a disservice. So it's really important to say, hey, what is our goal? Not only the number, right? I don't like numbers on the scale, even though that's, a very objective measure. I want to know, like, number one, when your blood pressure is lower, when you're just feeling better. I even ask patients, how do your clothes feel on your body, right? So that's really important. And it is not just, hey, take this medication, good luck, see you next year, right? We need frequent check-ins. We need to make sure we're all being accountable. So moderate intensity, like I said, it's around, 60 to 70% of your heart rate. And this improves insulin sensitivity, the visceral fat. What does that mean? I can talk while I do them, but I can't sing. You don't want to be doing super strenuous activities for 150 minutes a week. But some dancing, biking, canoeing. I don't think anyone canoes in the desert, but, gardening. Yeah, that's true. Tennis, doubles, and all that. Water aerobics, walking, but getting your heart rate up a little bit, right? You want to break a sweat. That's really important. So what should we do? Get a metabolic baseline. See your doctor, get a fasting glucose, A1C, lipid panel, some liver enzymes, check your blood pressure, and maybe your doctor will check your waist circumference. It's one of those things that not every provider will do. I like to have my little tape measure out, but if it's a very intense schedule, it's not necessarily something that makes a huge change, but it is important. And just talk to your doctor, be like, hey, my friend got diagnosed with heart disease. What can I do? Is there any screenings that you offer? At what age can I do X, Y, Z? That's why I'm here. I really just want to empower you all to have that discussion with your doctor. Bring up any weight changes since starting retroviral therapy. Discuss your goals. What is the number on the scale that you like? And the main thing is also your doctor should feel comfortable saying, hey, that's not realistic, right? If someone comes in and they tell me they want to lose 200 pounds, well, that's probably unlikely to happen unless we make significant changes, and I'm happy to help get you there. but that's going to take time. It's also not 200 pounds in 3 months, right? So having those goals is really important. And ask them about a GLP-1 medication. I think especially primary care should feel comfortable with these medications moving forward. If you're seeing an HIV specialist or infectious disease doctor, see if they feel comfortable prescribing these medications. Again, we're kind of moving into that space where most providers do, but just have that discussion. You can also consider a dietitian referral and even mental health support resources. We have a growing aspect of those in our at our center at Behavioral Health Center, which is opening. Start small on lifestyle. I always tell patients, pick one small thing. If that's even parking further away from the entrance to the grocery store, further away from Starbucks when you get coffee in the morning, add 20 to 30 minutes of walking 3 times a week if you're not already doing that. Go to the gym, you know, you'll interact with people, gets you out of the house, which is also such an important aspect, right? Track your sleep. I know a lot of patients come to me and they say, hey, you know, my Oura Ring or my Apple Watch says this and that. So just have that discussion with your provider. And we have a lot of different electronics that you can use that can kind of help you as well. The most important thing is that really metabolic health is a critical and often underrated part of living well with HIV. And really, antiretroviral therapy does create real metabolic changes. These are not just, hey, eat less, exercise more. And you should be getting the standard of care. These GLP-1 medications are safe and effective tools, and hopefully, you know, your provider will be able to give those to you. And the most important thing I think we talked about earlier today is advocacy. I know you need to advocate for yourself. Every patient does, and you know, we're not perfect as providers, and sometimes we miss things too. So bring this up and talk to your doctor and say, hey, is this right for me? So the most important thing is actually suppressing the HIV, and there's nothing that's the most important thing that you can do to really prevent any cardiometabolic changes. Is just taking your medications, being undetectable. That's really the best thing. So yeah, that's it. Thank you. Thank you.
What are your experiences of using Egrifta?
Egrifta. I have not once again.
Testimonial, and it's a growth hormone, existing hormone.
Oh, is this the medication that's used for lipoatrophy?
Okay.
Yeah, correct. Yeah. So I personally have not prescribed it. I have read about it multiple times, and I think, you know, we need to get more comfortable. I don't know what the cost is and insurance coverage, but I have heard about that. Yeah. I have no experience with that one. Yeah.
So, yeah, the doctors are very familiar with it. They have a very aggressive sales team. It's lots of benefit. I'm sure you see them out there. I'm on it, it helps. It takes a long time. It's not overnight. And, you have to inject yourself every day.
You still have to mix it right.
Not anymore. They came out with a new version, I think it's called sustained release or something, but it comes with bacteria set water now, so you can do a week's worth and keep it, I don't know if you got the refrigerator. I just switched over to finishing up my old stuff, but yeah, you can mix it up and keep it drying in the same bottle from which really helps. And then in terms of what's that?
It does take.
Yeah.
I was in trial for 6 months.
Yeah.
Didn't see anything.
Yeah, and then people respond differently. It's like hormones, right? Everybody's different. And some people need to go 6 months to a year. So it's just much more. But in terms of reimbursement, they call the company. They have people who will help. You can tell the doctors what to write, what to say, and get it covered, push it through for you. Because it's everybody says no, because it is real expensive. It should cover everybody. Anybody else? Yeah, but
Did you say that the Ozempic also reduces the body fat, the belly fat?
So yeah, as you lose weight, it usually does come off of the belly. Oh,
I'm talking
sorry.
about the hard.
So yes, it will lose. So Ozempic, number 1, is FDA approved for type 2 diabetes. So we'd be talking about semaglutide, which is the, you know, GLP-1, the single receptor agonist. It will reduce fat off the belly as well. As you lose weight, it will come off. It's not like FDA approved specifically for the belly, but patients do significantly lose a lot of belly weight.
Thank you.
anybody else? No, thank you so much.
Thank you so much for having me. Thank you. Thank you.